Hello everyone, I am Dr. Jaya, Aishwariyagha, Assistant Professor from the Department of Oral and Maxillofacial Surgery in Vinayaka Mission Sankaracharya Dental College and Hospital. Today we are going to see about odontogenic tumors. Let's move to the topic. These are the contents we are going to see. Introduction. Odontogenic tumors are a group of lesions of the jaws derived from the primordial tooth forming tissues, which are nothing but the odontogenic epithelium. So what are the primordial tissues? These are nothing but the epithelium, mesenchyme and the ectomesenchyme of the tooth forming apparatus. So here you can see that these are the primordial tissues like Hertwig's root sheath and then cell rest of molasses, everything. And classification. Moving on to the classification, odontogenic tumors are basically classified into benign and malignant. So again, benign tumors are classified based on their origin into epithelial origin, mixed origin and then mesenchymal origin. That is, these epithelial odontogenic tumors arise from the epithelial tissues and then mixed odontogenic tumors arise from both epithelial tissues and then the mesenchymal tissues of the tooth forming tissue. And then coming to the odontogenic tumors of the malignant origin. So this is of separate classification. Benign odontogenic tumors are again classified into epithelial, mixed and mesenchymal, as I said before. So what are the epithelial benign odontogenic tumors? Those are the ameloblastoma, squamous odontogenic tumor, calcifying epithelial odontogenic tumor and adenomatoid odontogenic tumor. So mixed benign odontogenic tumors are ameloblastic fibroma, primordial odontogenic tumor, compound odontoma, complex odontoma and dentinogenic ghost cell tumor. Mesenchymal tumors are the odontogenic fibroma, odontogenic myxoma, cementoblastoma and then the cemento-ossifying fibroma. So these are the benign odontogenic tumors. Next, moving on to the malignant odontogenic tumors. These can be classified as odontogenic carcinoma, which again consists of ameloblastic carcinoma, primary intraosseous carcinoma, clear cell odontogenic carcinoma and then ghost cell odontogenic carcinoma. The other two are the odontogenic sarcoma and then odontogenic carcinosarcoma. The first one is the ameloblastoma, which is of epithelial origin. So it is a benign odontogenic tumor. The other names for ameloblastoma are the adamantinoma, adamantoblastoma, multilocular cyst. So according to WHO, ameloblastoma is defined as a tube neoplasm of enamel organ type tissue which does not undergo in differentiation to the point of enamel formation. So according to Robinson, it is a unicentric, non-functional and then intermittent in growth, anatomically benign and clinical persistent type of tumor. So Robinson definition is a universally accepted definition for ameloblastoma. It is most commonly seen in posterior mandible, that is the ramus and then the molar region are most commonly affected, and in the maxilla posterior mandible is commonly affected. Next, incidence. So 18% of all the odontogenic tumors are of ameloblastoma, and ameloblastoma is the second most odontogenic tumor. So pathogenesis. So from where it arises from the remnants of dental lamina, that is the tissues which form the tooth. The remaining tissues after forming the tooth may give rise to ameloblastoma. Next, cell rest of enamel organ and then epithelial rest of molasses or remnants of Hertwig sheath. Epithelium of odontogenic cyst. So previously there may be a cyst and then the cyst may not be enucleated properly, and if in such case, and then the remaining epithelium may give rise to ameloblastoma. Basal cells of surface epithelium. Coming to the classification, ameloblastoma is further classified into conventional or the multilocular type and then extraosseous or the peripheral type, unicystic type and then the malignant type. So coming to the conventional or solid or multicystic ameloblastoma, it is the most common ameloblastoma among the four types. It occurs mostly in the third and then the fourth decade. And then gender, there is no sex predilection. Site 75% it occurs in molar ramus area of the mandible, that is in the molar to the ramus area, and then 20% it occurs in the maxilla. So clinical features, how it looks like. It will be a hard lesion, so it will be a slow growing hard lesion, painless, and then there may be tooth mobility and displacement. So it presents as an intra or extraoral swelling causing facial disfigurement. So here you can see a patient with ameloblastoma where there is a massive growth of the mass of the lesion and then there is the facial disfigurement on the right side. Next, the vital structures can be compressed by the larger lesions. So as the lesion is growing, it may compress the nearby nerves or anything. If infected, there may be pain, paresthesia or sensory nerve damage. Unless or until then, it is asymptomatic. So coming to the radiographic features. So it is a well-defined radioloculant lesion with sclerotic margins. In simple, we can call it as there will be a soap bubble or honeycomb appearance. So histologic features. So there are, again it is classified into plexiform and then the follicular type. Two types of histological subtypes have been found, and then follicular, again it is classified into acanthomatous, granular cell, basal cell and then desmoplastic. Coming to the radiographic image, this is the ameloblastoma, multicystic ameloblastoma in the left posterior mandible, where you can see a multiple cystic lesions, but it is a single ameloblastic lesion. So it is of multicystic type. Here, as I said before, there may be tooth displacement. Here the tooth is displaced. Next, coming to the histologic features. So this is the follicular type, and there is the islands of epithelium that resemble the enamel organ in fibrous connective tissue. So flexiform type, cord-like extensions of odontogenic epithelium may resemble the dental lamina, which forms a meshwork. And this is the granular type, where granules like appearance will be seen. So this is the follicular type, and then plexiform type, and then granular type. Among these, that is among plexiform and then follicular type, plexiform is the most common. Again, coming to the follicular type, acanthomatous is more common. So moving on to the treatment. So what are the conservative methods? One is the curettage, and then enucleation, surgical excision with peripheral ostectomy, and then surgical excision with other adjuvant therapies like chemical cauterization using cornoid solution or liquid nitrogen, that is the cryotherapy, or marsupialization. What are the surgical methods? That is a radical therapy, which is the resection with continuity defect or resection without continuity defect. So what is enucleation? So enucleation is nothing but a removal of the cystic lesion in toto, that using either a curette or like Waxman curette, like that. So the lesion should be removed in whole. After that, enucleation, this is one method, that is enucleation can be done in alone, or else enucleation can be done with along with adjuvant therapies like peripheral ostectomy, where the bone should be removed after removing the cystic lesion. And after that, chemical cauterization can also be done following enucleation. This is all about the conservative methods, which is the enucleation with peripheral ostectomy, and then enucleation with chemical cauterization. So next is the radical methods, which is the resection with continuity defect and then resection without continuity defect. So this is the resection without continuity defect, that is the their minimum inferior border should be of 1.5 to 2 centimeter, which should be preserved after the resection of the lesion. And if the lesion is too large, we can remove fully, like including the inferior border of the mandible in case of a large cystic lesion like this. So here in this case, they have removed the complete lesion and then a reconstructive plate is being placed. And then, but the curettage rate is highly recurrence rate. So there is a highly recurrence rate for curettage in case of ameloblastoma for about 55 to 90%. So coming to the unicystic ameloblastoma, it mostly affects the younger patients of second decade, and then there is no gender predilection. Posterior mandible is more commonly affected. Clinical features: lesion is frequently associated with the crown of unerupted third molar, that is the impacted teeth, and often resembles a dentigerous cyst. So it is asymptomatic. Radiographic features: it is a unilocular radiolucent lesion around the crown of unerupted teeth. So here you can see a unilocular lesion of around surrounding the forehead region. Whereas in multicystic ameloblastoma, you can see a multilocular cyst. Coming to the histological features, again unicystic ameloblastoma is divided into 3 subtypes based upon the histology, like a mural type, luminal type, and then the intraluminal type. Coming to the treatment, so the mural type is always a high recurrence rate than the luminal type and then the intraluminal type. So it is better to go with the local resection for mural type, and then for luminal and then the intraluminal, enucleation is preferred if it is a smaller lesion. And then enucleation is always the first line of therapy if it is a small. And then the 10 to 20% of recurrence rate is reported, after enucleation with all unicystic ameloblastomas. Next is the peripheral extraosseous ameloblastoma. Ameloblastoma in the gingiva or alveolar mucosa is termed as the extraosseous, as the name itself shows that it is outside the bone. So it is characterized by infiltrating into the surrounding tissues, mostly into the gingiva, without affecting the underlying bone. So here you can see a soft lesion on the lingual surface of the premolar region. It is a rare variant and affecting about 3rd to 5th decade. Slightly male predilection is there, and then mandibular premolar is more commonly affected than maxilla. So clinical features: lesion presents as exophytic growth, that is there will be an outward growth on the tissue. After that, coming to the radiologic features, there will be no radiologic evidence as it doesn't involve bone, and then only soft tissue lesion can be noted. So treatment, it is the wide local excision of the lesion. Metastasizing or malignant ameloblastoma. Ameloblastoma that occasionally undergoes metastasis or called as malignant ameloblastoma. It possesses the histological characteristics of a classic ameloblastoma, but as metastatic deposits in other parts of the body. Calcifying epithelial odontogenic tumor, which is the CEOT or the pin box tumor. So it is a locally aggressive but rare tumor. Has a unique feature which secretes the amyloid-like protein, which often calcifies. And then the pathogenesis is the epithelial remnants of the enamel organ. So clinical features: the age is the middle age, 30 to 50 years, and then the most commonly affected site is a mandible, then maxilla. So it is more common in the molar premolar region than in the end region. Incidence: it is less than 1% of all odontogenic tumors. 50% of all the tumors are associated with unerupted tooth. So it is a painless, slow growing lesion, and then it is also an expansible hard bony swelling as like ameloblastoma. Radiographic features: the unilocular or multilocular radiolucency. It can be either unilocular or multilocular with a well circumscribed border or diffuse lesion. So we can say that multilocular lesion may have an honeycomb appearance. So dry and snow appearance is nothing but the calcifications, that is the amyloid like protein which is secreted in this tumor calcifies, and then it gets deposited in the radiolucent lesion, giving a dry and snow appearance. So this is the dry and snow appearance. Coming to the histologic features, there will be amyloid like material seen in the histology, and then areas of calcification form concentric rings which are termed as Leising's rings. So the treatment is conservative local resection with marginal clearance. So this is the Leising's ring. So moving on to the adenomatoid odontogenic tumors. The other name is the adenoameloblastoma. Lesion that has an inductive effect on the odontogenic ectomesenchyme, with dentinoid frequently being produced, or the adenomatoid odontogenic tumor. It is considered as hamartoma. Pathogenesis: remnants of dental lamina. So it is more commonly affected in younger individuals like 5 to 30, and then females are more commonly affected. The most common site is the maxillary anterior region than the mandibular anterior region. That to 65% of the cases are seen in the maxillary anterior. So 3 to 7% of tumors are of adenomatoid odontogenic tumor. So two variants: intraosseous or central type, or extraosseous or peripheral type. So intraosseous type is associated with unerupted tooth, and then extraosseous type is associated with erupted tooth between the two roots, associated with impacted permanent teeth, that is a canine teeth mostly. It is a painless, slow growing swelling, and then expansible bony hard swelling will be there. So well defined unilocular radiolucency with margin showing definite sclerosis around the unerupted teeth. Treatment: there will be a recurrence rare, so conservative excision or enucleation is more than enough. So the radiographic feature is that here it is associated with unerupted teeth. It is of intraosseous type, and then extraosseous type mostly between the roots. Moving on to the squamous odontogenic tumor. Other name is the benign epithelial odontogenic tumor. So pathogenesis: epithelial cell rest of molasses. Clinical features: 2nd to 7th decade, no gender predilection, and then most common site is the maxilla, and then incisor canine area, followed by in mandible. Premolar molar area is most commonly affected. Both jaws are equally affected, and then it is an asymptomatic lesion where mild pain may occur. Occasionally involved tooth may be mobile. So moving on to the radiologic features, it has a triangular radiolucent defect with or without a sclerotic border associated with the cervical part of the tooth root, that is the lateral to the tooth. You can see a triangular like radiolucency. So here there is a triangular like radiolucency distal to the 7. Islands of mature squamous epithelium in a fibrous connective tissue stroma are seen in the histology, and then treatment local excision is enough. So this is the histology. And then ameloblasttic fibroma, it is a rare odontogenic tumor, simultaneous development of epithelial and mesenchymal tissue. So this is of mixed origin without the formation of enamel or dentine. Pathogenesis, odontogenic epithelial and mesenchymal cells of the enamel organ and dental papilla. Clinical features, first and then the second decade. Incidence 2% of all odontogenic tumors or of ameloblastic fibroma. So no gender predilection. Most commonly posterior mandible is affected, that is 70% of the ameloblastic fibroma will be there in the posterior mandible region. So it is a painless slow growing mass. There may be a disturbance in the tooth eruption. So radiographic features, it has a well defined unilocular or multilocular radiolucency with sclerotic border, and then 50% of the lesions are associated with unerupted teeth. So here you can see that there are multiple unerupted teeth, and then it is associated mostly with the unerupted teeth. Lesions are of 1 to 8 centimeter. So histology, cell-rich mesenchymal tissue in which the odontogenic epithelium is predominantly dispersed. That is, more the mesenchymal tissue is there, and then the epithelial tissues that are also seen. Next, treatment, enucleation and curettage is done as it is encapsulated, that is the tooth is unerupted and then over that there is the capsule like form, so that enucleation is done. So odontoma, this is the most common odontogenic tumor. So the second most common odontogenic tumor is ameloblastoma, whereas the most common odontogenic tumor of all are the odontoma. Odontomas are considered as hamartomatous malformation than a neoplasm. Basically, two types of odontomas are there. One is the compound odontoma, and then the other one is the complex odontoma. Compound odontoma are nothing but consist of hard and soft tissues. Multiple small tooth-like structures are seen. So you can see a swelling in the tissue, whereas after that you can see multiple tooth-like structures in the area. Whereas complex odontoma, it is a conglomerate, that is nothing but a single fused mass of enamel and dentine which bears no anatomic resemblance to tooth. Whereas compound odontoma, it has everything like a normal teeth like enamel, dentine and pulp. So complex odontoma develops in place of a normal tooth either from the dental lamina or enamel organ. So here complex odontoma, it is present in the area of the normal tooth like the mandibular third molar, whereas the compound odontoma, it is present due to the repeated divisions of a tooth germ or multiple tooth germ budding off from the dental lamina may fuse and then give rise to compound odontoma. Clinical features. So age, first and then the second decade of life, both the gender is equally affected. Common site is compound and then the complex. Compound is the anterior maxilla and then the complex is the mandibular posterior. Compound odontomas are always more common than the complex odontoma. Both the odontomas are slow growing asymptomatic hard mass and then associated with unerupted or impacted teeth. Compound odontoma, a packet of malformed or drafted tooth-like structures surrounding a thin radiolucent area. So this is the compound odontoma and this is the complex odontoma, where complex odontoma is a irregular dense radiopaque mass where it is a single mass, whereas the compound is a multiple tooth-like structures, that is a packet of malformed or draft can be seen. Histologic features, compound odontoma, there is a tooth-like structure so completely formed, so it has a enamel, dentine, pulp, cementum, everything covered by a connective tissue capsule, so in a well-formed manner, whereas in complex odontoma, presence of mature dental tissues like enamel, dentine, pulp and cementum present, but it will be in a dispersed manner. There it will be well organized, here it is dispersed. Treatment, enucleation and then surgical removal may be done if it is large. Odontogenic fibroma. rare neoplasm of the mature fibrous connective tissue with variable amounts of inactive odontogenic epithelium. So less than 100 cases have been reported worldwide till now. So two variants are there, one is the intraosseous type and then the other one is the extraosseous type. So all the age group are equally affected from 10 years to 80 years. Females are more commonly affected, posterior mandible and then followed by maxillary anterior. So this is the odontogenic fibroma of peripheral type. Central type, it is a slow persistent growth and asymptomatic lesion where the cortical expansion is seen, and then peripheral type, it is present on the gingiva. It can be either pedunculated lesion or sessile lesion. Large lesions may cause loosening of the adjacent teeth as the lesion grows in size. So radiologic features will define unilocular radiolucency with sclerotic borders often associated with apical area of the erupted teeth. Large lesions are multilocular. Root resorption and tooth displacement is so common in this cases. So treatment is enucleation and then excision. So excision in case of peripheral type and then enucleation in case of intraosseous type. So moving on to the odontogenic myxoma. The other names are myxofibroma, odontogenic fibromyxoma. So it is the third most common odontogenic tumor after ameloblastoma and then odontoma. So benign, non-encapsulated, slow growing infiltrated tumor of mesenchymal tissue. The mesenchymal portion of the tooth germ, either the dental papilla or the follicle or the periodontal ligament, is responsible for the odontogenic myxoma. Clinical features, it occurs from the 10 years to 50 years, whereas it is more common in children. There is no gender predilection. Site, mandible is more common than maxilla, that to the tooth bearing regions, not in the ramus area, usually unicentral but may cross the midline also. Facial asymmetry may be prominent. Asymptomatic, slow growing swelling of the jaw with the overlying mucosa uninvolved. So radiologic features, unilocular or multilocular radiolucency with well defined or moth-eaten margins. The radiographic feature is that it has an tennis racket or honeycomb appearance. Step ladder like appearance with a scalloped margin. Teeth may be displaced or resorbed. So here you can see a tennis racket appearance, and then the teeth is displaced. The adjacent teeth are also displaced. Histologic features, both myxoid and then the hypocellular due to the overproduction of glycosaminoglycans, which is the feature of this tumor, and it is characterized by stellate shaped angular or rounded mesenchymal cells in the homogeneous mucous stroma. Treatment, enucleation and curettage can be done for unilocular lesions of 1 to 2 cm in diameter. Wide excision is needed, followed by reconstruction if larger lesions. Radical treatment is done for recurrent cases. So this is the histological image. Cementoblastoma. So the other name is the true cementoma. It is a true cementoma of cemental origin. So here you can see in the name itself, it is of cementoblastoma, so cemental origin. So pathogenesis, connective tissue of the periodontal ligament and then the dental follicle give rise to the cementoblastoma. So clinical features, it occurs in the second and then the third decade. There is no gender predilection. Equal frequency of both the jaws and mandibular lesions attached to the single tooth. Maxillary lesions are usually attached to more tooth. It is a slow growing but eventually produces a large lesion and then expand and resorb the lateral and then the medial cortical bone. Associated tooth is vital, though the adjacent tooth is displaced and then it gives a lateral pressure. The tooth is vital. Painless bony expansion. Radiologic features, radiopaque lesion attached to and replacing the root of involved tooth. So here you can see it is attached to the root of the involved tooth, but the tooth will be vital. Extraction of the tooth and enucleation of the mass is the only treatment, because we can't do an enucleation without removing the tooth. So obviously the only treatment for cementoblastoma is extraction of the tooth and then followed by enucleation of the mass. To conclude, posterior mandible and cuspid areas of the maxilla are the most common site for the odontogenic tumors. Detailed history, thorough radiological and clinical evaluation followed by biopsy is important for diagnosis. Conservative and aggressive surgical treatment has to be decided according to the size and extent of the tumor. Proper aesthetic reconstruction should be carried out to avoid facial disfigurement. Thank you for watching the video.